Randy Vagelos, one of our cardiologists, is going to talk about carcinoid heart and what to do about it and how to recognize it. Thanks, Randy.
You're welcome. Thanks for inviting me. The shortest speaker, I guess, so I can. Anyway, I'm always impressed at the very positive impact these foundations can have, I think, towards, especially towards guiding patients to people who really have a familiarity with a disease or a syndrome, because I think what you want is expert opinions. You want the input of people who've seen many patients, not someone who's looking for their first exposure to a disease, because that would be fun to take care of. And I am not someone who has a practice of patients who have carcinoid heart disease, but am part of a division of cardiology in which a lot of unusual scenarios play out, and so that when you come to the Stanford Cardiology Group, you will almost certainly end up finding yourself taken care of by someone who has an aspect of expertise that would contribute probably positively to your scenario. That may not be possible for everyone, and I think what's so important about educating yourself is realizing, especially with something like the cardiac manifestations of this illness, that you need to bring forward to your caregivers the possibility that you might very well have a cardiac complication. And this is, I will get to that in a minute, but it's nearly ubiquitous. And so for you to promote yourself as someone who might have a cardiac complication of this illness is to a huge advantage to you and probably your caregivers, to remind them. And there's so much overlap between problems people have that this will be the case. And so, the idea here is, to make sure the puppy isn't lost in the efforts. Now, I mean, this slide, of course, is Gary Larson, but I think again, as you're looking to people for care, you want to make sure that they are caregivers who really have an experience with a particular illness and aren't saying that this would be nice to do. So when we deal with the cardiac manifestations of carcinoid syndrome, I think we deal with an overlap of these very active short clinical scenarios, which many of you experience, which can destabilize or lower the threshold for other cardiac problems. But we also deal with a chronic and progressively debilitating complication of these tumors. I think you've heard a lot about the various factors which are released into the bloodstream, both intermittently and sometimes at very low levels continuously. And what's interesting for us as cardiologists is the overlap between these various compounds that are released into the bloodstream and bad actors we know of that can have an influence in the cardiovascular system, either because they're vasodilatory and they drop the blood pressure and they stimulate the nervous system, or because they can have really a negative impact on structures in the heart. And serotonin is a particularly bad actor in that respect, so it's something to keep in mind in that way. The episodic flushing you've heard about and is fairly ubiquitous. It's always interesting to me is that from a patient standpoint, these are crises, but we as physicians only really describe them as a crisis. I think it's if they're long enough that you call a physician, and then suddenly it's a crisis for the physician. But they are all part and parcel of the same acute blood pressure drop and sympathetic nervous system activation that you experience when you're exposed to these active, multiply active release properties. The blood pressure will drop for most people when they have either a short spell or a longer carcinoid crisis. Inevitably, unless you're somehow compromised in terms of your response to the drop in blood pressure, your heart rate will go up. And that in itself can be a very unpleasant phenomenon for people. That becomes much more problematic if you're unfortunate enough to have other cardiovascular limitations in which the drop in blood pressure or the increase in heart rate starts to create a secondary phenomenon, if you will. And you can imagine if you already had limitations to your coronary arteries, or you already had valvular heart disease, or you already had a weak heart muscle, or you already had compromise of the blood vessels to your brain, that if the blood pressure fell and the heart rate went up and the adrenaline levels came up, that this could be really a secondarily debilitating phenomenon. These tumors arise in an age group of patients in which there's a tendency to have an increased experience with cardiac arrhythmia, which is an irregularity to the heart rate or heartbeat. And we see lots of patients in whom, in this age group, just increasing sensitivity to caffeine and alcohol and chocolate will bring out these arrhythmias. But the association between arrhythmias and these crises is very high. We have a patient in the cardiac care unit right now who is a carcinoid patient in whom the crisis precipitated a very destabilizing arrhythmia, which is what, in the end, brought her to the attention of sort of the cardiology service. But it's not an uncommon or unfamiliar association. You've heard about some of these precipitating factors, and I think it probably varies quite dramatically from patient to patient. I think what you want to take away from your own experience is some longitudinal confidence as for what you can do to minimize those things that drop the threshold. It is interesting that there are patients in whom other age-related or personal related phenomenon overlap with either the symptoms of these crises or the same kinds of stress-related phenomenon. And menopause can have its own impact that's similar. Emotional distress can both set off these crises, but can create these conditions. And even anaphylaxis, an extreme reaction, a drug reaction or a reaction to food can simulate this. There are a number of drugs that we in the cardiovascular world use that can simulate and precipitate some of these crises because they are very vasoactive. They make people flush, vasodilate, nicotinic acid maybe being the most common. It really isn't a drug that anyone can tolerate who has carcinoid syndrome. We use this for cholesterol lowering. And Viagra turns out to be a drug which is nearly ubiquitous in some of our population. Is a drug that a lot of people with carcinoid are just unwilling to take because of the overlap and a sense of what they feel at the beginning of a crisis. There's certainly other malignancies that can masquerade with similar phenomenon that we as physicians have to look out for. And I think most of you are aware of the appearance of and the sensation of a flush, so you don't need to hear about that. Well, so the cardiopulmonary manifestations sort of divide themselves into the acute things that patients experience, and then the chronic effects of this syndrome. Bronchospasm is not ubiquitous for sure, and may very well be more common or even limited to the patients who have the tumor limited to the lung itself, but I suspect it's more common than that because, at least in the literature, 10 to 20% of patients will have these episodes. And what's really critical as you take your symptoms and your syndrome to caregivers is that you, in your own mind, realize that this is probably not asthma and shouldn't be looked at as asthma. In fact, if the typical therapies for asthma are given for a bronchospastic response to a carcinoid syndrome, you will precipitate even more problems. The beta agonists that are used acutely for bronchospasm will just lengthen and promote the nature of a carcinoid crisis. So that's something that to bear in mind. I think, depending on where you go for health care, if someone who has a diagnosis of new asthma who's somewhere between 40 and 60, that should automatically set off some kind of warning as to whether they're really pursuing the right diagnosis. So that's the lungs, and that's certainly not the majority of patients, but some. From the standpoint of the heart itself, there is a sort of chronic aspect of the carcinoid syndrome, which has to do with a slowly developing change in the structure of the heart. And that's the buildup of these plaque-like fibrous layering over the valves and the inside lining, for the most part, of the right side of the heart. This limits itself to the right side of the heart for a fairly simple reason, which is the blood flows from the gastrointestinal tract, both directly and through the liver, into the right side of the heart. And then the blood flows from the right side of the heart into the lungs, and the lungs function as a fairly effective filter for the bioactive substances which we think are the source of this problem for the heart. So that it's very seldom that you actually have changes in the left side of the heart related to carcinoid syndrome. There are two scenarios in which you do, and one is if you actually have a hole in the heart which allows these substances, the serotonin probably being the most important actor, to go from the right side into the left. And so if someone did have problems with the left side of the heart, you would I think, be ahead of the game to ask if that was a problem. The other patients who will have problems on the left side of the heart are patients who have a tumor that's actually in the lungs. So it's releasing the serotonin and coming into the left side of the heart. So, that is fairly easy to understand. Now, this is a cartoon of the heart, and this is the right side of the heart here, and you have blood comes from the head down through the superior vena cava, and blood comes through the inferior vena cava from the gastrointestinal tract. And we think that the chronic exposure to these high serotonin levels cause this fibrotic encasement, if you will, of the right atrium and the base of the tricuspid valve, which is here, which over time scars the valve to the point where it really doesn't function to keep the blood from moving backwards on the right side of the heart. The blood goes from the right side of the heart into the pulmonary arteries, and the pulmonary valve and pulmonary artery itself can also develop these plaques. And so for 90%, if not more, of the patients with carcinoid who have heart disease, it's going to be on the right side of the heart. And the good news about that is that it's very well tolerated. Most patients can have a fairly dysfunctional tricuspid valve without being particularly debilitated. The bad news is that most patients who have significant tumor burden will have, over time, a progressive disability of the right side of the heart. Cardiac involvement, as defined by these changes in the right side of the heart and the tricuspid valve and the pulmonic valve, is seen in the majority of cases, and in some patients is the initial manifestation. So I only remember one patient in whom the echo lab saw very typical abnormalities to the tricuspid valve, in which that alerted to the primary team that maybe the diagnosis was carcinoid as a syndrome, because so many of the patients have the carcinoid, the crises already as a phenomenon. In any case, the lesion is progressive and tells us to some degree, if it exists, that it's likely that the liver is also involved from the standpoint of the carcinoid itself. And whether that's because the lesions in the liver are actively contributing to the serotonin load, or whether it has to do with clearance of the same, no one knows. But clearly that there is a correlation between the extent of heart-related involvement and the extent of liver-related involvement. There have been a lot of, I think, optimistic, if not hopeful, proposals that aggressive serotonin suppression might decrease the progression in the cardiac pathology. But as far as I know, there's been no evidence to date that even with successful suppression, that has been successful. On the other hand, it's pretty clear that the higher the levels of serotonin in the blood, in general, the more advanced the cardiac involvement. So there clearly seems to be some correlation between the two.
Dr. Vagelos, you have your 5
Okay, fine, thank you. So the symptoms that relate to the direct cardiac involvement unfortunately sometimes overlap quite a bit with the rest of the symptoms one has if one has a systemic illness like this and takes drugs which have a lot of side effects. And fatigue and effort intolerance are often the early symptoms of the same. And in fact, I have many of those symptoms at the end of every week. So I mean, it's part of the human experience. And as I mentioned, tricuspid valve abnormalities can be tolerated quite a while by the heart without causing problems. So by the time you have the actual manifestations of a failing right heart, which is a tendency to retain fluid, both in the abdomen, in the lower extremities, and in the lungs, you tend to have a scenario in which the valve is likely very dysfunctional. By that time, the effects of having high pressures in the right side of the heart start to dominate the presentation with the whole illness. That is, loss of appetite, loss of dry weight or muscle mass, along with this fluid retention, which has a fairly dramatic impact on functional capacity. Once the heart starts to fail on the right side, there is an incidence of arrhythmia which goes up, and that, for some, is the first manifestation of the involvement of the heart, especially if no one has said, oh, you have carcinoid as a syndrome, we should look at your heart in terms of involvement. Many people who have had tests long before the diagnosis has been made that would have suggested involvement of the heart, just a chest x-ray, which everyone gets basically as protocol when they come into the hospital, would show an enlargement of the right side of the heart if looked at by someone who is thinking about that. And certainly fluid in the bases of both lungs would be pathognomonic for a failing right heart. The EKG also is done almost always when someone's admitted to the hospital, and any non-regular rhythm is likely to be related to the kinds of distortions in the heart that are associated with this phenomenon. The echocardiogram is something that should be done at baseline in any patient who has carcinoid syndrome to get a sense of where you are at that point, and should be done certainly in response to any change or development of new symptoms related to the same. This is what we look at in an echocardiogram. This is the left side of the heart here, and it's a little bit like buying a stereo. You don't have to be an expert, you just have to compare. But in this particular patient, the left ventricle here is smaller than the right ventricle. Oops, let me go back one. And the left atrium is smaller than the right atrium here, which is huge. And what we don't see is those valve leaflets actually touching each other. They are scarred and frozen so that the blood will leak back from the right ventricle into the right atrium. And this is depicted by this Doppler signal in which the blood is moving backwards from the right ventricle into the right atrium. And you can imagine if the right ventricle squeezes and all the blood goes backwards, how ineffective that is from the standpoint of cardiac output. Symptom control you've heard a little bit about, but it turns out that suppression of the serotonin really has not been shown, at least in the trials to date, to decrease the progression in the valvular lesions seen with this scenario. What we do from cardiology is often manage some of the manifestations of the late stage of the disease when it's often diagnosed, which is to get rid of the extra fluid with diuretics, which really can be amplified by salt restriction and fluid restriction. We try to correct and identify abnormalities in the heart rhythm. This particular woman who was in the hospital with a heart rate of 180 needed to have an electrical cardioversion of that rate, and that really dramatically stabilized her. There are drugs which can control the rhythm, but there's also a very old drug named digoxin which increases the vigor of the right side of the heart, which can be very helpful to patients who have this problem. And then it's important, especially because there's a tendency to always think that one problem explains everything that's going on, to think that there may be other causes of valvular heart disease in someone who has carcinoid as well. Most specifically, an infection of the right side of the heart that one could get as a complication of the therapies that people are getting. Valvular replacement is something that can be done in carcinoid, and if one looks at the literature of the risks to it, or I should say the risk associated with surgery over the last 25 years. 25 years ago, the series suggested that 25 to 50% of the patients who had a valvular replacement from carcinoid-related heart disease would be dead within a year, and now the survival has improved dramatically, such that the quoted risk is about 10%. But that potentially may be because we are recognizing the problem earlier and sending patients who are really in better shape for these surgeries. But it's certainly possible, if symptoms are controlled and the disease is controlled, to think about a valve replacement in that context. I think at this point I will stop, and I appreciate having a chance to talk to you today.
Thank you. So the first question I have is, when should a neuroendocrine tumor patient see a cardiologist?
All patients with an identified carcinoid tumor should have an echo at the beginning of when their disease is identified, to get a baseline. And then should any symptoms arise that would suggest a cardiac limitation, whether it's more shortness of breath, a tendency towards fluid retention, or electrical arrhythmia, they should be seen. I don't think necessarily, if they don't have cardiac involvement at the beginning, that they need to be seen regularly by a cardiologist. But I think if that first echo suggests that there's a cardiac involvement, that it would be very helpful to be under a cardiologist's care.